That's correct.
Thank you, my lady. Professor Harries, before lunch, I think you made the point that testing didn't stop at any point completely, or contact tracing, and perhaps that's referable to clarifying what happened after the 12th of March and the movement from the contain to the delay phase. But then, building on that, can I ask you a question, please, by reference to the quote attributed to yourself linked to the test. I'm going to first take you to an Irish Times report, but then I will give the full context from within your statement, your fourth statement. So can we look first of all, please, at the Irish Times article, which is 474852. And if we can move to page 2, please. We can see you were referenced there by reference to test, linked to what had been said by Tedros Ghebreyesus. And then you were suggested as saying test was intended for countries less developed than Britain. And over the page, please, to page 3. Thank you. We can again see, again, selective quotes from you relating to, so the point there is that they're addressing every country, including low and middle income countries. So encouraging all countries to test of some type. And so I think this is the foundation for a question I'm going to ask you about, but I know in particular that the context to this quote, you're anxious to be considered. And so please can we then move to the full context that you provided linked to the comments made on the 26th of March 2020. Can we move to INQ 273807 at page 145, paragraph 10.18. Thank you. And so we've looked at aspects of what you said within the Irish Times article, but we can see that you address this within your fourth witness statement, giving the full context, I think, to what was said. And if we go over the page, please, we can see in particular at at the end of paragraph 10.18, again, further context that you've highlighted in bold. So obviously, if there was infinite testing facilities and we are growing them at pace, we will have them, then it moves to the public. But we need to be very careful about focusing where it's clinically most valuable. And then if we go and just expand out again, we can see further you give context to this conversation at paragraph 10.19 and 10.20. So there's wider context there. But can I ask you, do you agree that essentially what was said by you around these quotes linked to the 26th of March ignores the fact that other countries with at least as well developed public health system as the UK were at this time testing extensively at a rate many times that in the UK?
So thank you for showing the complete section there, which I think the Irish Times does not pick up fully, and I would encourage the inquiry to look back at the detail of what I've said. I think that's important. What I actually said, and I think you showed it was encouraging all countries to test of some type. That included the UK. The reason that I flagged the low and middle income countries was actually because at the time, 80 out of 194 of the WHO countries had not reported any cases at all, and WHO was including and exhorting all countries to do so, regardless of what their constraints. Some of them were political, I think, and many of them were the lack of capacity. And in fact, the UK had been supporting them, and that was exactly my point. So I felt that perhaps that had been misconstrued, and I was actually encouraging countries and other countries to support those without testing capacity. The other point I think that you've flagged there is, and I mentioned this just before lunch, was that back around as we were moving from contain to delay, there had been a change in advice. Public Health England had published that change back on the 14th of March, and I think my comments there were made on the 26th of March, so they were following effectively that movement in the change of the case definition. and targeting the testing that was there towards those cases where it was most appropriate. And if I remember, this detail actually goes on to flag that if you, whatever testing you have, you need to use it effectively. If you're using it in community testing, where most people are likely to do well, and not using that for those who need the test for clinical benefit, you will disadvantage the people who need it.
Thank you. Can we next move, please, to the topic of capacity, please? And I asked you before lunch around international experiences, but can I ask you, did the UK fail to mobilise TTI resources at an early stage and emulate the approach adopted by countries such as Taiwan, Singapore and South Korea? First of all, do you accept that as a proposition?
So I think international comparisons generally are extremely difficult, and I know many people who've commented here and put in statements and in other modules have flagged the differences. It's not simply what testing capacity you have or how you might use it, it's actually the context in which you're using it as well. So for a country like Taiwan or South Korea, which I visited myself, there were some very, very, how should I put this, non-libertarian interventions for individuals. So for the things like the use of credit card details to know where individuals were travelling. So as well as a very, very highly developed digital infrastructure. So on top of the points I've made earlier, which is actually, I don't think, it's not just the UK. I mean, Germany is flagged as a country which had a lot of testing, but the testing fell over, I think, in the second wave as well. I don't think many countries outside the ones that you have mentioned, which are predominantly around Southeast Asia, and I think probably had learnt from MERS more effectively and had very highly developed infrastructure systems, did very well in this space. So I wouldn't necessarily pull the UK out as different to other countries. But obviously what you see in the development of the activity and the startup of Test, Trace and Isolate is a decision, and I think it came on the 17th of March at a roundtable from at number 10 I wasn't at, where there was clearly a ministerial decision to move to building a testing capacity for the country, which had not been envisaged before.
Thank you. And so can I seek your views? Would you agree that there was a failure to take proper account of international experience and expertise in establishing the TTI system?
I think that's a different question, if I've understood it correctly, which is, did people look to see what systems had been developed elsewhere as they developed TTI? Is that the question? And I don't think that is the case, because there were a number of different strands of, there are automatically a lot of links that we have with different countries. I've just mentioned we have MOUs with different countries, so we can ring colleagues up and ask what they're doing. But I think more importantly, Cabinet Office, right through the pandemic, actually ran a comparator, an international comparator. So I think people were looking for international experience to help and support them in how they developed a service.
And can I then take it back a step in terms of you identifying that South Asian countries had learned from MERS and SARS? Do you think there's an identified failure to not respond effectively in preparedness to look to what South Asian countries were doing, informed by the experience of SARS and MERS?
I think in retrospect, and I say I'm not singling out the UK from this, given my points earlier about planning through for a different, for example, a disease with asymptomatic transmission, or more importantly, I think, is this mindset which says we can actually stop a pandemic. And that, I think, is the critical learning point for the future. I think for those countries who were very nearby, I mean, we have had MERS cases and we have managed them perfectly effectively. So that in itself is slightly problematic, because if you manage an infection effectively, perhaps it reinforces the idea that this is, you have systems that work. And evidentially we have done that. We haven't had epidemics emerging.
Thank you. Can I then please take you back into your fourth witness statement, please, to paragraph 9.41 at page 135, which is INQ 273807. And this is on the question of discharge to care homes, please. You say this: I'm aware that in an email of the 14th of April 2020, The Chief Medical Officer's advice was that testing within care home settings was a priority, following concern highlighted by a recent study of 39 care homes, indicating potential high rates of nosocomial transmission. The issue of ingress into residential settings was one of significant clinical consideration, including at the Social Care Working Group, where work streams were delivered on an ongoing basis through the pandemic to support testing policy development and changes, including for individuals being discharged from acute care settings to care homes. However, despite clinical support for discharge testing to be undertaken as soon as possible, testing was not initially available at the scale necessary to achieve the objective. And you go on, any system of testing prior to discharge from hospital into care home settings would have been dependent on there being sufficient tests available, as well as ensuring the appropriate process parameters, such as time of test, time period over which a test remained valid, turnaround time of the test result, were agreed and evidence-based. These were fundamental considerations for the Social Care Working Group work programme. Can I ask you then, are you aware of any analysis in March of 2020 of the testing capacity that would have been required to implement mandatory testing prior to discharge to care homes?
Not specifically at that point, but it's given that we know what the testing was capacity, and I think it was, from memory, it was somewhere between 5,000 and 10,000 in mid-March. And on the 17th of March, there was a roundtable where the country was, where ministers agreed to start developing a testing system. That would not be a difficult test. It's a number. That wasn't the planning issue. I think the issue was that the country was starting to develop a large testing system. It would be very easy to calculate the numbers that were needed at that point.
Thank you. And then following on from that then, are you aware whether there's any consideration given to implementing alternative measures in the event of an anticipated shortfall in testing capacity, such as deferral of transfers into care homes until testing could be implemented, and or mandatory isolation of patients to mitigate the risks of transmission?
So this is going to quite a long space outside testing. So if I just go back to the previous question, I seem to remember, and I can't remember who said it, listening to some of the previous representatives, that there was an email from Ros Roughton. It may have been Mr. Hancock, actually, who there was a series of hearing information presented where it was made very clear that she had calculated. So she was the Director General for Care at the time, and on the afternoon that the decision was made, they had actually calculated how many tests were required. So I think that is, and it was going to be difficult, both in practical terms to do, as well as the delivery of the test, because clearly you need to ensure that staff on the front line in hospitals are able to do that and process the results and what have you. So I just going back to that one, I think it was calculated. That was not the issue. The second point is a very, very different one, because actually, and probably a point I should have made right at the start, on all of these issues, the test is not the intervention. The intervention for safety is the isolation. The test is an adjunct to all of this. And even if you have a test, if somebody doesn't act on it and self-isolate, then this is not really of any validity. It might give you surveillance information, but it won't protect anyone. And so when we come on then to care homes, actually the critical intervention here was about keeping the patient safe. And the safest thing for these, and I can reference back, I'm sure, to a number of other inquiry documents, is staying in hospital, if you're usually elderly and frail, is a very dangerous place to be. So that is not a helpful thing to be retained there. And importantly, even if you have had a test and it is negative, it doesn't mean you won't develop. It's only negative at the point the test is taken. So the really critical intervention for the individual and for the care homes who were receiving them was for the individual to go into isolation after they moved. So testing at this point is an adjunct, but it is not the main intervention for keeping an individual safe.
Can we then please look briefly at your paragraph 4.33 in the UKHSA corporate statement, please, which is the 587365 at page 46, please. That's 4.33. Thank you. You say this: in September 2020, after schools reopened, the UK experienced a second wave of infection resulting in further lockdowns across the United Kingdom. It was anticipated that the winter would create a dual challenge of managing flu and COVID-19, and the UK government wanted to avoid a second lockdown. NHS Test and Trace was therefore asked to expand PCR testing capacity with a target to meet processing of 500,000 tests per day by the end of October 2020, already part of the July 2020 NHS Test and Trace public plan. And so can I then ask you, you have had provided to you statements from Professor Fulop and Professor Pagel around the second wave. And so can we briefly look at Professor Fulop's statement, please, which is 575990 at page 3. 575990. So 575990. Sorry, I think this is actually Professor Pagel's then, I do apologise. But in any event, if we look at paragraph 8, it details that essentially it details about symptoms, but then if we go over the page, and particularly to paragraph 22, please. It again details essentially the predicted autumn second wave. And then, thank you, if we can then go to Professor Pagel, please, which is the... Sorry, I do apologise. Sorry, I'm going to start this questioning again. So if we can start, first of all, with Professor Pagel, thank you, 575988. Thank you, which is paragraph 36 on page 14, please. Thank you. We can see here reference to the tests, but also increase in prevalence from September onwards. And then please, if we can separately then deal with Professor Fulop, which is 587244, paragraph 19, please. Again, thank you. If we can go to paragraph 19 to 21, essentially the same point, identifying the failure to prepare for the second wave. If we move over to paragraph 21, please. Thank you. And so can I ask you, do you agree with Professor Fulop and Professor Pagel that the United Kingdom had failed to prepare adequately for the predicted autumn second wave, including by failing to improve testing, tracing and isolation, despite calls for such improvement from bodies such as the Academy of Medical Sciences, SAGE and Independent SAGE?
So I obviously was nothing to do with test, trace and isolate at this time, so it's difficult for me to be absolutely clear beyond what I've put in the statement about what preparations were made. I know there was a winter plan and actually it took a lot of those into account. I did notice in reading through that Professor Pagel had said much of this was predictable, and of course all the bits that one would think about, people going inside more because it's cold and mixing, I, as far as I can see from the evidence, was actually considered. The only thing I would say is I don't think it was actually predictable because these were some of the least predictable winters that we had. If we looked, actually, flu didn't go up in the way you thought it would, it went down, and children's illnesses changed because they weren't mixing. So, so it varied quite a lot. I think it really is just highlights that planning throughout this phase was incredibly difficult for all sorts of people, for the health services, and particularly, I think, for, which I experienced later, trying to predict, for example, the number of LFDs and then actually moving that through a procurement system and sign-off. So, as I said, beyond that, I don't think I can really add more to what's in the statement.
But wasn't a second wave predictable? Just putting to one side winter, I thought the evidence I'd heard with people like Sir Patrick, now Lord Valence, and Professor Whitty were advising of the possibility of a second wave or the likelihood of a second wave quite early on.
So waves are definitely predictable,
Yeah.
and I think one would anticipate this, that there would be other waves. So that's absolutely the case. The precise point and severity of a wave is not. And actually what this highlights, and I agree with Professor Pagel in the sense of, we know what the normal infectious disease patterns are during winter. And so what you had then is not being precisely sure of when it was going to come and knowing that if they hit together, it would have one impact. If you hit in close succession, it might have another. So, for example, if you did have a wave of flu and then you had a wave of COVID, you would have them building on each other. You'd have people remaining in hospital from previously. If you have COVID and everybody locks down, you won't have the flu potentially, and so it goes on. It's the point I think is there are predictabilities around winter normally, but this was not a normal winter, and you can predict new waves, but you can't predict precisely when they come, which is why the surveillance is so important, because you can start to see where those peaks and troughs are happening.
Now, obviously, you've identified winter, but I particularly want your views, please, before September 2020. What preparatory steps should have been taken by NHS Test and Trace before September 2020, and in particular during the period of low prevalence over the summer of 2020?
I'm happy to make some general comments, but I think those are probably questions that were better addressed to Baroness Harding, because it's difficult for me to be precisely sure what measures were taken. I wasn't involved in that. I would have seen general plans come forward. Obviously at any point during the pandemic preparedness, you want to have a reasonable amount of tests, but you will have to vary that with the controls, which I think we've heard from ministers on deciding about costs and expenditure. And I think, as I suspect Baroness Harding has said, but I would certainly endorse if that's the case, that was particularly difficult because the flexibility to turn on additional resource for procurement and then actually get the products in, bearing in mind that much of it was in high demand globally and was being produced overseas, was incredibly difficult. So whether or not the planning was there may not have resulted in, all of the capacity that you may have wished for.
Thank you. Now, we looked before going to Professor Pagel and Professor Fulop's statement, your statement, which had identified the second wave after schools reopened. And can I ask you now some questions, please, about testing in schools? And could we please display paragraph 4.117 at page 68 of your statement, please? Thank you. In fact, if we go back a page again, please, I think we can see the section where you dealt with testing in schools. Thank you. And so we can move up a page. Thank you. Now, you tell us in the witness statement that mass asymptomatic testing was implemented after schools and further education colleges reopened. We're now in March of 2021, following the national lockdown. And asymptomatic pupils initially tested at ATSs within their educational settings, supervised by staff. And I think tests were repeated on site for pupils, ideally at a 3 to 5 day interval, and for staff twice weekly through self-tests at home. And then as we see at 4.117, after 2 weeks, pupils moved to home-based self-testing when the levels of self-test stock available allowed. I think you've also had provided to you the paper from the Secretary of State for Education titled Asymptomatic Testing in Schools. And if we can just briefly display that, please, which is INQ 75484. That's INQ 75484. Thank you. And if we move in particular to page 6 of this paper, paragraph 13. Sorry, we'll go back a page, please. Again, it details core proposition will require asymptomatic test sites to be set up in every secondary school and college. You've also, I think, had a chance to review the statement of Kate Bell, where she specifically deals with the fact that schools were informed of plans to implement asymptomatic testing in schools on the last day of term in December 2020. And the reference for all that, although I don't think it needs to be displayed, I think you've had an opportunity to read it, is INQ 587569, paragraph 96. Can I then ask you, please, Professor Harries, do you consider that sufficient plans were in place to enable asymptomatic testing in schools to be effective?
So first of all, the tests need to be effective, and I think you've highlighted there, I'm very familiar with the fact that many of the tests actually could not be used, although we've all got used to that now, were not able to be used for self-tests because they weren't accredited that way through MHRA at the time. So I think that there's a practical issue there. I'm afraid the rest of it is not my domain. It's clearly a decision made by the Department for Education. I'm sure they're much more familiar with what schools are able to do or not. My experience of teachers during the pandemic was they were absolutely wonderful and delivered a huge amount. But whether or not that was practical for an average school, I think, is for the teachers and the Department for Education to answer.
And then can I ask you, from your public health expertise perspective, would you agree that testing regimes in schools should have had greater involvement from persons with specialist expertise from local public health, and those administering, supervising the test should have been provided with better training?
But you didn't know what the baseline was before you could say they should have had better?
And I would also add a comment about we need to, for the reasons which I flagged at the start, which is, local public health. I have worked in local public health. If I had been part of this team centrally, would that have been adequate input or not? I mean, there is a general point here, and it's one that UKHSA tries to work toward, which is around co-production of all of this guidance. And I suspect that Baroness Harding will have flagged that, which I know is the case, that as NHSTT developed, they tried to move more of their services and the way that they did things to the community and work with a community, and absolutely recognise that. But I think, these are different demands in a very fast-moving space. But I wasn't directly involved, so I don't think I can add more.
Well, then, finally, can we go back to your statement 587365 at page 68, please? And if we could just look at the statistics you have helpfully provided in the corporate statement, which is at paragraph 4.117.1. That's INQ 587365 at page 68. Thank you. You've helpfully provided the statistics. Reported participation varied between secondary school pupils, 27%, college pupils 8%, primary school staff 43%, secondary school staff 34%, and college staff 15%. Although it's considered likely there was underreporting of negative self-tests conducted at home. In the light of those statistics that you have been able to provide, are you able to assist as to what are the lessons to be learned from asymptomatic mass testing in schools?
So I'm just trying to look at the point above this. Again, this is not a piece of work I was directly involved with at all. And if I'm just reading very quickly, I think it says focusing on a 5-week period from the 1st of March 21 to the 4th of April 21. And obviously how effective something will depend on a whole load of other contextual areas. So one of the things about testing, which I am aware of in schools, is at different points, actually it was very... the pupils and staff found it very supportive. They found, and I think one of the general endeavours, this is standing back from this particular element, was we all recognised how important it was for children to be in school. That was an absolute priority. And so to support and encourage individuals back to school, testing can actually be quite a supportive, it gives them confidence to be there. The timing here, to me, suggests that you can also find that people, their engagement diminishes. And so I'd be interested on this one, we perhaps would be helpful to compare what happened in January and February with March and April, because I know from my own experience from some of the care home testing was that actually, depending on the regimens and whether you were PCR or LFD and at which point in the pandemic cycle it was, people were more or less engaged with it. So I think that's probably all that I can say. I don't think we should assume that those apparently low numbers that, necessarily mean it was not effective, and we need to define what we mean by effective at the end of it. If more children were in school and they were healthy, that probably has extremely long-lasting positive effect.
Thank you. Can we then please move backwards to your paragraph 3.40, please, at page 27 within this witness statement? And I want to see, please, Professor Harries, if you can assist us a little bit more on asymptomatic transmission and testing and prioritisation. And we can see there from the 15th of April 2020, PCR testing will be offered to everyone who needs one in social care settings. The press release stated that all symptomatic care home residents will be tested. All patients discharged from hospital were to be tested before going into care homes as a matter of course, and that all social care staff in need of a test would now have access to one. And obviously the caveat, of course, this depended on the availability of tests. Now, the inquiry had evidence that by March of 2020, it was established that there was credible evidence of asymptomatic transmission and that PCR tests could pick up asymptomatic cases, meaning that there was value in testing people with and without symptoms, even if those tests were not 100% sensitive. Now, you've referenced there the announcement of the 15th of April 2020 about testing in social care settings, including the commitment that all patients discharged from hospital would be tested as a matter of course. And therefore, can I ask you, in light of this, do you agree that the measure should have been adopted earlier, and particularly when the COVID-19 hospital discharge service requirements were published on the 19th of March 2020 to promote discharge in order to free up hospital beds?
I think I'm probably going to repeat myself slightly because we established, I think, on when the prioritisation of testing note was established on the 8th of March by PHE and then was put out on the 14th of March, that there couldn't have been testing on the 19th of March. So, I mean, the basic point is you would need a test to implement this. So I think that would not have been a possibility, notwithstanding whether it was desirable. There is a second point, which is we start with the premise that asymptomatic testing and the risks were completely understood, I think, in March. In fact, and I think, again, Mr. Hancock made these points in his evidence, at the start of April, and I've made it, you've actually pulled up my own evidence here, there was a particular study in the US, in the Seattle care home, which gave a lot of strong evidence with very good data and denominator factors of asymptomatic transmission. And then PHE actually did what's known as the Easter 6 study in the Easter weekend, which gave us, if you like, homegrown UK figures for the first time, which were really robust, and then went on to do some more detailed evidence. So I think it was generally around April time, which is when the reality of the proportion of cases, if you like, of asymptomatic transmission was recognised, and that is exactly why the Department of Health moved quickly for their 14th of April announcement and this one actually. So I think on the one hand you need a supply of tests, so it's they can't have put something in if it wasn't there. And secondly, I think, as far as I can see, it was put in as soon as the evidence base was clear for the country.
And can I just pick up with what you've just said about the prioritisation list?
Yep.
Can we briefly look at, I think, the 11th of March prioritisation list, which is INQ 00270014. I hope that's the correct reference. 270014. Thank you. Now, we can see the prioritisation list devised, I think, by Public Health England on the 11th of March 2020. And so just building on the question I asked you a moment ago, should that have been amended to include all patients being discharged into care homes at that time?
So the basis, I mean, this is an evidence-based, clinically agreed proposal that I think was put forward by Public Health England and considered by the UK CMOs and a number of other senior clinicians. So this is an agreed position. It predominantly runs with those individuals for whom, at this stage, testing was required for the management of their clinical care. And you can see that running all the way through. So this feels the right prioritisation. I don't think anybody that I've spoken to since has looked back and felt this was wrong for the test capacity and the clinical care requirements at the time. And also bearing in mind, of course, we're still quite early on in the pandemic to understand what the different outcomes might be for different groups.
Can we then next move to a new topic, please, on symptoms? Now, can we display, please, INQ 151498? That's INQ 151498. Thank you. Now, you tell us in your fourth witness statement, so rather than going to the statement, I thought it better to look at the email itself. You refer to the note of advice you gave to the DHSC on the 20th of February 2020, listing symptoms associated with COVID-19 infection, saying top ones are in order: history of fever, chills, cough, sore throat, general weakness, runny nose, headache, muscular pain, diarrhoea, shortness of breath. And can I ask you, please, what involvement did you have in identifying the symptoms which were communicated to the public as sufficient to require or trigger symptomatic testing for COVID-19?
Just for clarity, this is an email responding to Miriam Wright, who actually headed up the visual aids and communication side. So this is not clinical advice to the Department of Health or anyone else. Usually what would happen is they would be crafting pictures or posters and they would pass them through myself and Professor Van Tam to see if we could spot the obvious issues. Second point is, all of those symptoms you've just listed, as it says in the email, are the ones which had come from a release from WHO. So these were not my advice, these were the ones which WHO had put forward. So this is not advice to clinicians or to the Department of Health, it's what WHO had said. Notwithstanding that, your question is, usually it wasn't my responsibility. I would perhaps see end results or that came into senior clinicians group for observation, for recognition and discussion, but all of the symptoms which arose would routinely be looked at and reviewed, because the importance of symptoms is that you have a very high positive predictive value if you're going to use them, and you can't put 99 things out in a list to the public, because actually the whole of the public would come forward with something. So I wasn't directly involved. Often it would be colleagues in NerveTag, for example, so Professor Van Tam, Sir Peter Horby, Andrew Hayward, and it would be those in Public Health England who were looking at the evidence base.
Thank you. I appreciate the clarification you've given to this email. Perhaps if I just summarise how you referenced it in your fourth witness statement, please. You say this, it's your paragraph 7.23, I don't think it needs to be displayed. On the 20th of February 2020, I emailed DHSC advising them of the symptoms associated with COVID-19 infection in order to respond to questions on material to be included in social marketing health promotion messages. And so can I then ask you, please, given the range of symptoms that we see identified in the email, and particularly you identifying the source of that being the WHO, do you share the concerns expressed by Professor Spector about the impact of relying solely on testing and the 2 to 3 symptoms of COVID-19, fever, cough, shortness of breath, that essentially remained as the list until loss of taste and smell was added on the 18th of May of 2020?
So these are two separate things for the reasons which I've just said. So I don't think we should consider this as advice. As I said, it's for social media. And in fact, I think I note somewhere it's very early on. This is around the, 20th of February. So I think Professor Spector, from memory, didn't actually start using the app until around the 23rd, I think, of the next month.
That's correct. And certainly by the 1st of April, he had identified and indicated loss of taste and smell was a strong indicator.
But he wasn't the only one, obviously. There was and all of the new symptoms that arose, and there were numerous symptoms, would be considered and through an evidence base. And in fact, there were 3 different groupings for symptoms that were recognised reasonably early on. One was what you might call the respiratory ones, which were predominant probably. There were a group of neurological symptoms, and there were a group of gastrointestinal symptoms. The important thing is that you can't go out to the public with every symptom. What you actually have to do is get the highest sensitivity and specificity in those listings that will give the greatest care to the population. Otherwise, you'll flood the symptom. I mean, the other issue is, I think, that when Professor Spector raised those points, I think we were in lockdown about then anyway, so I think we need to think through the practical implications. Key point is those symptoms, and in fact, Professor Spector's work was actually funded by the Department of Health between 2020 and 2022, and I know that colleagues in NerveTag were in continuous communication with him. So I did listen to his evidence, but I think he may have been slightly mistaken about some of the communications.
Well, then can I ask you, as a proposition, certainly using the 1st of April and the loss of taste and smell, would you agree that those symptoms should have been added much sooner than the 18th of May of 2020 as indicators of infection for COVID?
So regardless of whether it was anosmia, agousia or any of the other symptoms, only if they were going to deliver the greatest benefit for the population in getting them the right care at the right time. And my point is that, and I think, and I'm fairly sure it has been disclosed to the inquiry, if you look at the conversations between colleagues in NerveTag, particularly Sir Jonathan Van Tam, they were asking from Professor Spector for the data in order to make the appropriate comparisons and to get the right grouping. And once that moved to, and it did change actually through the pandemic as well, then those symptoms were included. So this was all symptoms, including anosmia, were under consideration right the way through, and it is the grouping of those to give the right sensitivity and specificity that were the ones that were utilised for the public.
Thank you. Can we then please move in your witness statement, please, the 587365, please, to paragraph 3.77. So it's page 36 of 587365, please. Now, this falls under a run where you deal with contact tracing. Sorry, the statement deals with contact tracing and the development of the COVID-19 app. And if we can then, you give update figures, and they are, please, if we can move now to 4.144. Again, pardon. Sorry, page 74, please. Thank you. Can I ask you then, just generally on the app and Wales, can you assist as to what consideration was given to the population in Wales who did not have smartphones or may have had challenges due to technological literacy?
I don't think I'm going to be able to, apart from the fact I am a Welsh resident, so I could make comments about the signals in Wales, but I don't think I can, because I wasn't involved with the development of either the first app or the second. And whilst we did work very closely with Wales, I wasn't involved in this particular bit, so I don't think I can help any further with that.
Can we then just complete the questions on the app then, please? Can we move forward to page 74 and paragraph, in fact, sorry, it's 75, 4.146. I think you give details within the statement about the priority was ensuring it was broadly accessible, the languages, and can I ask you, was the data obtained about the number of uses of the app in languages other than English obtained?
I don't think I would be able to answer that. I can. It would be probably a good question for people like Professor Fraser, who I think you've spoken to.
Thank you. And then can we move forward to your paragraph 4.151? And again, we have specifically asked Professor Fraser about this. You reference at 4.151 and 4.152, essentially the success stories of the app when it was available after the 24th of September, including downloads, uptake and prevention of hospitalisations and the like, including deaths averted. For time, I'm not going to display it, but I think you've had an opportunity today because you referenced the Nature article as the foundation for these statistics. We've asked a number of witnesses who've relied upon the data whether or not they can assist with the map that shows almost universal low uptake in Wales. Can you cast any light on that?
I'm afraid I can't. I mean, obviously, I felt as an agency preparing for pandemics, I should understand whether the apps have been useful or not. And I think there's a universal agreement that they are. They're not the only thing, but they have been very successful in saving lives and preventing cases. But the distribution across Wales, I'm afraid I can't.
And can you just bearing in mind all the positive things about the app have been quoted by way of the data as to whose task it would have been to look at that, what appears to be a trend of very low uptake across Wales?
Well, I think if I was sitting in Public Health Wales at the moment, I would, which I have done previously, I would be very interested to understand that. And I do think it is important to understand the technology sitting behind it as well, because obviously you there is a gadget and an app to use, but you have the area of Central Wales, for example, I know from my own past experience of being Director of Public Health there, is very sparsely populated, so you would not expect to have significant high uptake, and actually signals are very poor. I was joking before, but this is a fact, and so people may not have found it as useful to do that. I think this is one that we talked about local understanding, and this is exactly the sort of area where you would need local insight both to the digital infrastructure, the telephony infrastructure, and actually utilisation by people in communities.
Thank you. Can I next move then, please, to support for self-isolation? And can we move to paragraph 6.32 of the 587365 statement at page 100? 587365. Thank you. We can see at paragraph 6.32, you detail that the financial support provided under the Test and Trace Support Scheme, and you say this finances can act as a brake on the ability of those who are otherwise willing to self-isolate. That can be because they're in precarious employment or have been told that they do not have recourse to public funds. Well, this is not a matter that falls directly within UK HSA gift. It is an important point which was highlighted during the pandemic and continues to be so because it has relevance to the ability to control the spread of an infectious disease. From historic experience, this is both for population and individual disease transmission risk. And so can I ask you, do you consider that the TTSPS and the discretionary support scheme adequately address the issue which you identify, that finances can act as a brake on the ability to self-isolate?
So I think adequately is a challenging word, but the point about, for example, precarious employment, I think it's precarious lives. I think Professor McKee mentioned this. It is very obvious that if you live hand to mouth day by day, you need to know that you have an income, and if you don't have that and you have demands on your finances, you're very unlikely to engage in these sorts of settings. I think that is evidently obvious. I know that NHS Test and Trace, I know that the Secretary of State, I was in personal meetings, was really trying to promote this and make sure it was understood across government that this was, it may be a financial burden on the country, but actually it would have financial implications in terms of the economics of the country as well, in terms of extending potentially the length of the pandemic. The issue I've put at the bottom there, and this was actually, it reminded me particularly of a meeting that I was in with the Secretary of State on this topic at the time, which was this is Matt Hancock, he was trying to understand how we could do this, what the challenges might be, and also how important it was. And I had flagged that through my time working with communities on infectious disease, this is a recurrent problem. If you have a case of something and somebody needs to be, you advise them to be off school or off work, but they are not ill themselves, this is actually a major block to their engaging with that intervention. And he actually asked us to go away and see if we could come up with something which we could utilise both for COVID and for this. And because it was actually extremely difficult, and so my recommendation at the end of this is that actually it does need looking at, not, I mean, obviously with UK HSA support, but it's a DWP Treasury, I think, opportunity, because it affects the economy, and we do not want infectious people going in and out of work on a routine basis, as well as during pandemics.
Now, with giving that answer and also the identification that it's not within UK HSA's gift, has that view been fed back as to those relevant departments that really need to make grip this issue in peacetime?
I think it's very well recognised. I mean, I think most people who have been working certainly on the front line for this have made this point recurrently. I think it's become, it was perhaps hidden for routine health protection cases, but it's well known amongst those, as I say, working whether in local authorities or actually whether in UK Health Security Agency and predecessor organisations. I'm trying to think. I think we have formally raised it in many of the products that we've published. We've looked at inequalities. We did a review of the interventions, so those are available and will be available to other government departments. We've put everything into the public domain.
Thank you. And can I ask, has that included any consideration about whether the £500 support payment that was introduced in England was sufficient?
So I think you can see through the evidence that people suggest it's not. It feels, logically, it feels relatively little to encourage somebody with family, for example, responsibilities to be immediately staying out of employment. Clearly, there is a demand on the public purse for that, and that's why I think it is entirely appropriate and reasonable that the Treasury is the centre point for consideration of that alongside DWP. But the precise amount and how it's administered, I think, needs some wider thought. I don't think we can help, but I don't think it's our domain.
Thank you. Can we then go back to paragraph 6.5, please, on page 92? You detail that the pandemic highlighted the need for more agile, responsive and comprehensive approaches to health inequalities. Pre-pandemic planning did not fully account for the scale of inequality revealed by the COVID-19 pandemic, particularly in emergency response scenarios. Given that extent of health inequality was known, can you assist as to why pre-pandemic planning did not really engage with this issue fully?
So I think anybody working in health protection knows that a pandemic and infectious disease generally will follow in the wake of inequalities. That's nothing new. The inequalities agenda I don't think is recognised enough routinely. It was the point I was making before the break, and it's one of the reasons why I have right from the start of UKHSA had a strategy which highlights inequalities and the need to reduce them. We have our inequality strategy, but most importantly now, we are increasing the data that we are putting out to effectively ensure that other parts of the system, so for example, trusts and ICBs, are able to look at the data and understand it for their areas and actually take action, because that action will allow the health of the population to improve and the economy to improve, but it will mean we are much more resilient in all of our communities the next time a pandemic hits.
And can I ask you, does that analysis of data now include also disaggregated data?
So wherever we can, we are working to do that. And in fact, I think I made some comment. There was a Public Health England heat tool before, but we have built in a number of what I would call automatic checkpoints. So if we are doing emergency response, inequalities immediately gets flagged up for our emergency response. It's inescapable, if you like. If we're looking at data, we're asking the questions. We don't always have the data, and I think this is an important point. If it's not disaggregated when it is collected, so if a survey is not done with data which can be disaggregated, then clearly we can't then analyse it and look at what the impacts and the outcomes are likely to be. But wherever it is, we do, and if we find areas where we want to know more, we will be pushing back on those data streams.
Thank you. Can we just go to the next paragraph, 6.6 and over the page? You've just referenced, 6.6 there, thank you. You've just referenced the heat tool. Are you able to assist as to when that was actually brought in?
So this was actually a Public Health England introduction. So again, I wasn't directly involved with it, but I was aware of it. And I think it's an example of ensuring that everybody who is working in health protection, emergency response, but actually routinely as well, when you're planning services or looking at any intervention, consistently looks at the inequalities lens. Now, I would say most public health trained individuals do that routinely, but it also doesn't hurt to be reminded to do it absolutely systematically, not as a tick box exercise, but actually to say we have this data, we don't have this data, and have a feedback cycle to go back so we know if it's not there this time that we can improve it the next.
Thank you. And just on a further topic, we know that latterly targeted testing came in. Can you assist as to why that wasn't introduced sooner to essentially assist with sort of groups that were hard to reach and engage?
Do you mean the targeted community testing?
Yes.
I mean, that was very much introduced. The start of that was the community testing programme, which again predated UKHSA. I think I go back to the comments I made earlier on, and I know from having come in behind Baroness Harding, there was a growing recognition of the importance of community engagement, but I think a growing evidence base as well about underserved communities who do not necessarily engage through the same routes, do not feel comfortable. We don't make it easy for access, but I'm probably picking up my Director of Public Health experience and know that those communities are very well known in local authorities, and that's probably where the starting point should be.
Thank you. Now, finally, for my purposes, under lessons learned and recommendations, can we thank you and UKHSA for the 14 pages of reflections which are contained within the witness statement? But can I pick up on a couple of issues, please? Can I ask you, first of all, we heard from Professor Fraser linked to apps, that it was his evidence and understanding that it would take 3 months to deploy a new version of exposure notification in a pandemic. First of all, is that accurate, and is that the current position?
Well, Professor Fraser would probably be better informed to give a precise timeline than I personally would. But I think two things. One is we did consider this very carefully. There was a ministerial decision to decommission the app, but along with many other things, we've had pathogen-specific, so COVID-specific interventions where we actually are trying to grow systems routinely which can search for anything and are pathogen agnostic. So this didn't fit that, and I think we recognise how valuable an app can be. We have explored to a degree, again within our budget, what would be possible. We do not have that in active consideration at the moment, partly because we actually do need to understand what our budget settlement will be going forward and how many of these different interventions and programmes we have running we'll be able to take forward. Final point is, I think that as we've seen during the pandemic, the 3 to 4 months could well come down with the right budgetary input and the right ministerial direction at the time, and we would obviously respond to that very quickly. Most importantly, we have good connections with people like Professor Fraser, and so we can automatically link with them now in perhaps a way which was not there at the start of the pandemic.
Thank you. Professor Harries, you will have heard, no doubt, Lord Bethel's evidence essentially about how we've gone backwards in the last 3 years, not forwards. The diagnostic infrastructure is dismantled, data spine closed down. Obviously, you deal with aspects of UKHSA's preparedness for a future pandemic and appreciating it could be any pathogen. But can you assist? Is UKHSA currently in a position to effectively fulfil its role to provide the UK's standing capacity to prepare for, prevent and respond to infectious diseases and other threats to health?
So I think the short answer is within the budget envelope that we have, but we have programmes in progress. Lord Bethel's comments I agree with in some ways, which is many systems have been decommissioned, but I think it's important to realise, as I've just mentioned with the app, that the majority of those were built very quickly, quite expensively, for one pathogen during the pandemic. And what we are trying to do is go back, so they will have been decommissioned, and we are trying to rebuild a system, which we are partly doing, to get to a point where the country can surge, so to our boundary envelope. So we have got a new, for example, equivalent of the CTAS system, the community tracing system in development. We've got a prototype. We're working on an H5N1, so avian flu PCR model, so that, but something that in the future can be used for any pathogen. So even on a daily basis, if we have an outbreak in a region, we could use this, but we can extend it out to national levels. And I think I've outlined a lot of these issues there. The bit that I think, and perhaps if I could indulge a few minutes, that I think where we are missing out is we do not have, and this is one of Lord Bethel's point, the production capacity, if you like, to, for example, to make our own LFDs. And yet we in UKHSA are developing techniques which might mean we don't need large quantities of the PCR testing capacity. If you can take from an LFD the viral RNA and find that out, you actually avoid the need to have any of the community PCR testing. So we have set up a diagnostics accelerator, but it's not linked in right across government to investments which would allow spin-off companies to build those up for production lines and some of the digital infrastructure. And I think my sadness as I leave my post, let's put it that way, we've done lots of work with the private industries because we need to do that to be better prepared. We're working on the 100-day mission and we've described the priority pathogens and worked out which tests we don't have and which vaccines we don't have. So we have a roadmap, if you like, for the UK to build on. But actually, the civil service is quite a clunky system to get to unite. In a way, there will be a new life science plan, I think, a life science sector plan, which will be helpful. And so I think government is very much in this way. But actually, the civil service itself does not enable some of these logical investments, interventions and connections, which otherwise I think could be win-win-win. So we don't have empty factories and we don't have empty buildings. We're using them for developing life sciences routinely, and then we can turn them all logically together at the event of a pandemic.
Thank you. And then can I just ask then finally, for my purposes, to get to that joined up system and with the identified issue linked to the clunkiness of civil service, who has to be part of that collaboration to get that joined up system?
So nominally it is there. I'm being very realistic as I leave post because it is one of my frustrations. We've done a lot of, as I've outlined there, a lot of what I would call front-end work. We are working very closely with industry, but if I go and ask some of the industry colleagues I've been working with, they will tell you there are 5 or 6 different front doors to come through. And I know the government is currently working on that. And so the ambition and the vision is exactly as I think it should be. I actually think the culture, if I'm being entirely honest, and I'm critiquing myself because I'm part of it, needs to move into a 21st century in the same way that we need to move forward in our thinking about actually stopping a pandemic. And that's my term about scientific preemption is, yes, we need big testing capacity, but most of the time we shouldn't need to get there. We should have done a lot of upstream work. We should have tests more or less available. We should know who we're linking with, and we should have colleagues in production, in private sector, who are working with us routinely, all with appropriate governance frameworks that we can just turn on and go. And it's those same connections which, out of a pandemic, could be supporting life science growth.
Thank you. Professor Harries, those are my questions. My lady, there are core participant questions.
Ms Parsons, I think, is going first. Who's, if you look that way, she'll right.
In fact, my lady, in light of evidence given already, we don't need to ask our question of Professor Harries, but thank you very much, my lady.
Oh, well, thank you very much, Ms Parsons. Right, Mr Thomas.
Good afternoon, Professor. I'm Leslie Thomas, representing FEMHO, the Federation of Ethnic Minority Healthcare Organisations. I only have a small handful of questions for you. FEMHO members found it nearly impossible to feed back to those in charge about the practical issues associated with the TTI policies. Help us with this. Why was it not possible for expert healthcare workers to provide feedback from the front line with the aim of improving the services for ethnic minority individuals?
So I think this probably relates to NHS test and trace, and obviously I was only responsible for the last part of the journey. So I can only say really what we're doing in UK Health Security Agency now. I think there are 2 points. One is I would hope and expect that the early comment on that for the future would go through for the different health organisations, and actually we have means of picking that up both at national level and local. Particularly we work through directors of public health as well very closely. So each of our local health protection teams usually has a nominated actually consultant who will link with the director of public health for a patch. So that's one very good route. I think the other one is we work manage with the Department of Health and NHS England a voluntary organisation oversight group which should allow for information to feed back in. But I think the obvious practical answer is I hope we are very responsive to any routine requests that come in, and we have a routine system for doing that.
Yeah. So you would agree that there should be such a pathway?
Well, I think there should be a pathway for anybody to feed back on services. We should have strong customer services. I think my problem is I didn't set the TTI agenda at the start, so I'm not really very able to be helpful with that, with the early phase of development.
Milady, there was one other small question that arose out of Ms Cartwright, Casey's question. May I ask it? It's very short.
You may, Mr Thomas.
I'm most grateful. Professor, just one question that arose in relation to the questions that you were asked about whether the UK should have taken more heedance from what was happening in Asia. Can I just follow up on that, just in this way? Do you believe there were missed opportunities for the UK to learn from countries that successfully managed their COVID testing and tracing and isolation response, particularly not just from Asia, but also from Africa as well? Do you think the lessons could have been learned?
There's a general point here, I think. You're inviting me to say, should we learn from other countries? We absolutely always should, and we do. And in fact, actually, UKHSA works very closely with Africa CDC. We actually have somebody embedded in that country, and we actually have 2 teams out. So I myself have been out to Nigeria, for example, and we liaise very carefully. We support surveillance systems in other parts of the world. So and my experience from it always is it is two-way learning. It's never one way. There are lots of things. And actually, importantly, as we go forward, we haven't mentioned it, vector-borne disease will come to the UK. And colleagues in Africa are experts. And we have to learn from other countries in our preparation.
Milady, thank you very much. Those are all my questions.
Mr Jacobs, right down the end.
My lady, my question was on financial support. In fact, I don't think I can take it further than the questions and answers given. So
I'm very grateful to you and Ms Parsons for curtailing the questions you need to ask. Thank you very much. That completes the questions for today. I'm afraid you may have retired, but you can't escape my clutches. So I'm going to have to ask you, I think, come back for the next module, I think, isn't it?
Yes. One more, I hope.
Yeah, but I do appreciate the burden on you, as I've said many times, and of course on the UKHSA. So thank you very much for your help to the inquiry so far. I hope the next time I'll be able to say goodbye and a proper thank you.
I would like that too.
Very well, I shall break now and return at 25 past.
Thank you, my lady.
My lady, the next witness is Mr. Fell.
I do solemnly,
sincerely and truly declare
and affirm
that the evidence I shall give shall be the truth, the whole truth, and nothing but the truth.
Sorry, the last witness of the day, Mr. Fell.
It's okay. Someone has to be.
They do, I'm afraid.
Good afternoon. Please could you tell the inquiry your full name?
Thank you. I'm Greg Fell.
Mr Fell, you've provided the inquiry with one witness statement dated the 30th of April 2025. It's inquiry reference 000587434. It should be coming up in front of you just now. At page 50, it's signed and dated with a declaration of truth. Can you confirm that you've read your statement recently and that the contents are true to the best of your knowledge and belief?
Yes, correct. Read it this morning.
Thank you very much. We're going to deal with the following topics in your evidence. Firstly, touching on your background and professional experience. Secondly, looking at an overview of ADPH and the role of directors of public health. Then moving on to the centralised approach, the TTI system, some data challenges, the directors of public health's role in respect of local contact tracing, self-isolation, inequalities, and lastly, your observations on any lessons to be learned for the future. So turning then please to your background and professional experience, it's right that you are currently the president of the ADPH, which stands for the Association of Directors of Public Health.
Yes, that's correct.
And you've been in that role since November 2023.
Correct.
And prior to this role, you were a Director of Public Health yourself in Sheffield for 10 years.
Correct. I still am a Director of Public Health as well. I've balanced the two jobs.
Thank you very much. So it's right to say that you held that role during the pandemic?
Yes, absolutely.
Thank you. And in terms of the ADPH itself, it's a representative organisation of the directors of public health across the UK.
Yes, correct.
And you work in partnership with other organisations, including a range of government departments, the NHS, local authorities and the like.
Entirely correct, yes.
And the ADPH represents the views of directors of public health on public health policy.
Yep.
And you advise on public health policy and legislation.
Yes.
And in respect to the COVID-19 pandemic specifically, the ADPH collated and presented the views of the directors of public health to help inform the government's response. Is that right?
Entirely correct.
And is it also right to say that the ADPH had a good working relationship with the local government association?
Very good then and now.
Thank you. We don't need to go into the detail of it, but it's outlined in your statement between paragraphs 21 and 39. In summary, the ADPH is governed by a board.
Yes.
There are 4 membership types.
Yes.
And as of October 2024, there were a total of 448 members. Is that correct?
Yes. Can't remember the exact number, but approximately.
Thank you very much. So the inquiry has heard quite a lot of evidence about directors of public health, and I'd like to ask you some more detail about their specific role and function. So can we go to your statement, please? Pages 10 to 11, looking at paragraphs 47 and 49. Starting, please, with 47. You say that the core purpose of a Director of Public Health is as an independent advocate for the health of the population and to give system leadership for its improvement and protection. Is that right?
Entirely correct. I could unpack that more if needs be.
Thank you. And you go on to say that it's a high-level statutory role which sort of bridges local authorities, the NHS and other appropriate sectors. Is that right?
Still correct, yes.
Thank you. And then briefly, please, paragraph 48. You say it's important to note that the purpose of the Director of Public Health and the core role is the same whatever the structures within which they sit across the UK.
Yes, in Scotland, Wales, Northern Ireland, the DPH is based in the health board or equivalent. In England, it's based in local government.
Thank you. And we'll come on to the devolved administrations in just a moment, and I'll ask you a bit more about that. Before we do that, can we look at paragraph 49, please? Here you set out more about the responsibilities of directors of public health. And just looking at the first 4 bullet points, you talk about being responsible for measurable health improvement, health protection including emergency response, public health input to health and care service planning and commissioning, and also the reduction of health inequalities.
Yes, that's entirely correct. Just one thing to clarify, emergency response would be with respect to a public health emergency, perhaps not a major fire. That would be a different part of the local authority and obviously the fire service. So it's the emergency response bit is particularly pertaining to things that are classed as public health.
Thank you very much indeed. And also just the next 2 bullet points, you talk about being an independent advocate for the health of the population, and also to be the person who elected members and senior officials look to for expertise on a range of public health issues, such as outbreaks of disease and emergency preparedness. Is that correct?
Entirely true.
Turning then to the devolved administrations, and you began to touch on this just a moment ago, and we don't need to go to it, but you deal with it at paragraph 52 of your statement. And you talk about there being a distinction between how the arrangements operate. And I think what you say is that in England, the directors sit within the local government, and in Scotland and Wales, they sit within the NHS on the boards. Is that right?
And the same in Northern Ireland.
Thank you very much. And just in terms of the numbers of directors of public health, are you able to assist us with how many there are in total?
175. I can do the proper count later and get back to you, but it's in that order.
Thank you very much. And I think you've told us that there's one in Northern Ireland.
Yes.
Are you able to assist us with how many approximately are in Scotland?
One in every health board. Slightly guessing now, I'd say it's about 10, 12, and one in every health board in Wales, which I think is 8 or 9. But
Thank you very much.
If precise numbers are needed, I can get those to you.
No problem at all. Thank you very much. And then in England, I assume the remaining numbers
Yes, correct.
Would be in England. Thank you. I wondered if you could help us with this, please. The inquiry heard evidence last week from Mr. Hancock, who was asked about the capacity of directors of public health to perform the role of contact tracing. And he said that the capacity was wholly inadequate because in the context of England, there was one person in each of the upper tier local authorities and therefore around 100 people. And my question is, we'll come back to capacity shortly, but in practical terms, is it just one director of public health as the individual office holder, or do they in fact work in bigger teams with shared expertise?
So we have a team. I have about 30 or 40 people in my team, and in the period of the pandemic, they were fully deployed on the pandemic and nothing else. So it's not true to say DPH were one man bands or one woman bands. We have a team. It's probably also true to say that we drew on the capacity and capability of the whole of the local authority, and we deployed them in contact tracing and a range of other activities with regard to managing the COVID pandemic.
Thank you. And would that be the same across all of the devolved administrations, that they would work within teams as such?
Oh, yes. I don't know the detailed arrangements for the COVID response at local government level in Scotland, Wales and Northern Ireland, but in England that's absolutely categorically the case. For the public health teams, i.e. my direct team, all of my oppos in Wales, Scotland, Northern Ireland will have a team of people.
Thank you. And then turning please to just exploring specifically relevant expertise that directors of public health have in relation to a TTI system. Can we go to paragraph 84 of your statement, please? It's page 19 over to 20. You talk about directors of public health and their teams have extensive knowledge of their communities and the wider health and social care system. They have a critical contribution to make in developing approaches that work on the ground and in ensuring solutions are tailored to the diversity of communities and the range of needs that exist, from language to inequalities. How was this particular expertise relevant in the context of a test, trace and isolate system, please?
So if we need to get testing rates high in response to an outbreak in a particular part of a certain town, and that happens to be a multi-ethnic, deprived part of town, there's no, to be overly blunt, don't give me a megaphone and tell me to stand on the steps of the town hall because I'm a middle-aged white bloke. Work with and through community and faith leaders, which all of us will know who they are in our towns, and that's how we get reach and trust in the message to the places where it's needed. That definitely can't be done adequately from national perspective. It has to rely on local contacts, local expertise, and importantly trust. That's in addition to all of the technical competencies that you'd expect directors of public health, importantly, and their teams to have.
Thank you. And just coming on to the more technical expertise, if we could look at paragraph 92, please, of your statement. You talk in this paragraph about directors being trained in containing infectious diseases, both understanding and interpreting data, recognising risk factors, understanding the evidence base, and what motivates behaviour change and helping develop policy interventions. Can you expand, please, on this particular paragraph in the context of developing and operating a TTI system?
So I would expect all directors of public health to be appropriately qualified and competent. They should be either on the GMC or the UK Public Health Register. Most of them have undergone a formal public health training programme that lasts 5 years, which includes all of those aspects of training and competency development and more. We'd expect all qualified public health specialists, some of whom are directors of public health, some of whom are consultants in public health, to meet the faculty's public health training requirements, which are set out in a very detailed curriculum, which includes all of those factors and more. Some of our teams will then have further specialisms and have deep knowledge in behaviour change, but would expect DSPH and their immediate consultant team to be fairly competent generalists across all of those aspects.
Thank you.
I couldn't ask you to slow down, Ms. Falconer. The poor stenographer's had quite a day.
Sorry, I have been warned, lady. Yes, I will. Apologies.
So I share the same feelings. I understand.
Thank you, my lady. And can we go to paragraph 93, please, where you talk about another aspect of expertise, and it's in relation to contact tracing. And you say, contact tracing is a tried and tested public health intervention. Directors of public health and their teams have experience and knowledge of contact tracing, their local communities and the wider health and social care system. You talk about within local government there being numerous people with the skills, from environmental health officers to public health specialists and sexual health staff, to support the contact tracing efforts in response to the coronavirus. However, the involvement of local councils and directors of public health in the test and trace service was, at the beginning of the pandemic, fairly limited. So would it be right to say we've looked at the three elements, we've looked at the local community expertise, we've looked at containing infectious disease and all those training requirements you've told us about, and we've looked at contact tracing. It's right to say that directors of public health had clearly relevant and applicable expertise to TTI matters. Would you agree?
My view is that's entirely fair. There is an important point. At the beginning of the pandemic was fairly limited. That did improve over the course of the pandemic. Our environmental health teams, that's what they do with regard to foodborne outbreaks. Our sexual health services, that's what they do with regard to containing sexually transmitted infection outbreaks. They're very, very, very good at it.
Thank you. And we'll come on to that. We'll talk about the improvement and sort of the timeline of that in due course. I wanted just to ask you some questions, please, about the centralised approach, which is a topic you touch on quite a lot in your statement. And I'm going to invite you to offer observations on that approach and the extent to which directors of public health were engaged sort of initially and later on. So we don't need to turn to it, but at paragraph 141 of your statement, you describe the structure of the test and trace system as opaque and say it was unclear where responsibility lay for different functions. Are you able to just expand on that, please?
Certainly earlier on, the impression, my impression and the impression of lots of directors of public health, as they've said to me, was that there was a predilection towards a centralised system that's run nationally for the whole of the country, with very limited involvement of local authorities, not just directors of public health, but local authorities in the execution of that service. Again, my recollection is I was never sure who was accountable for the totality of what became NHS Test and Trace, certainly in the early days, and there seemed many people accountable for different bits of it, but we weren't clear who was the person that was actually accountable and pulled it all together. And it was quite difficult to have conversations in that context. It's worth remembering the context of the time was a very, very, very fast-moving situation, and that is an important caveat.
Thank you very much. So just unpicking, please, some more of your observations around centralisation. If we could go to paragraph 143 at page 34 of your statement, please. You say here that money spent on private sector outsourcing was wasted since local public health teams already had both the knowledge and expertise of contact tracing and their local area. Consultants had to spend time with public health and wider LA teams in order to understand the local situation. The Director of Public Health view was that it would have been more efficient to use existing local systems and support them with surge capacity as needed. This national centralised system didn't work optimally for these reasons and required local systems to mend the service and to ensure the public was protected. So I just want to ask you specifically, you talk about consultants having to spend time with public health officials and wider LA teams. Can you just tell us a bit more about that specifically, please?
My recollection of my colleagues is we all spent quite a lot of time explaining to the contractors of the day, who did change from time to time and not infrequently, the situation on the ground for me in Sheffield or for my colleague in Derbyshire or wherever. That took time, and that took time for that person or that group of people to understand the local community organisations, what would and wouldn't fly, what would reach a community in a specific part of the country, and that would be different in different parts of the country because these things are by necessity local. A huge amount of energy and effort was put into developing a trust with our local communities. The pandemic largely revolved around trust, actually. Later on in the pandemic, when we had stood up with resourcing from government, local contact tracing teams, we found that we were able to reach people quicker and close the case, i.e. Trace the contacts and ensure that we'd made sure that there was isolation support available. We were consistently able to do that much quicker than the national service, which matters for disease transmission, obviously.
Thank you. And then if we can please look at paragraph 102 of your statement, which is at page 24 and over to 25. You talk about there being in the early stages, there being a significant disconnect between how policy was formed nationally and how it was implemented on the ground. You describe a top-down approach by government that meant that directors of public health were sidelined in terms of national decision-making and centrally run programmes such as testing regimes. And you say there was an assumption that decisions could be made at a national level that would be suitable for all local areas, and that proved costly as a one-size-fits-all approach was not effective. Can you just explain, please, more about the one-size-fits-all approach and why that wasn't effective? You've touched on it, but is there anything further you want to say about that?
Just to elaborate, for what would work in one part of, I'll pick a town, Wolverhampton, wouldn't work in another part of Wolverhampton because the conditions on the ground are different, the characteristics of the population are different, and the types of networks that were needed to reach those populations with some trust and credibility would be different. The same applies nationally. What will fly in Wolverhampton will be different to what will fly in Walsall. Hence, whilst it's not for directors of public health to be setting government policy, we aren't the government. That's not our job. It's not our job to be advising government on government policy because our responsibility is to our local populations. We consistently made the point that a one-size-fits-all approach wouldn't be optimal by some stretch, and we will help the government execute the most effective policy on the ground, but that would need to be necessarily different in different parts of the country.
Thank you very much. You provide further detail throughout your statement about the practical consequences of the centralised approach. We can take that down now, thank you. I'm just going to run through a few examples. We don't need to go to the statement itself, but for example, you say at paragraph 123 that DHSC, for example, did not have an up-to-date contact list for directors of public health, which led to delayed or absent communication. Is that right?
My recollection is that's definitely true and was an issue on more than one occasion during the pandemic.
Thank you. Another example you provide is that ambitious targets were set for testing, but without a clearly communicated rationale for the programme overall. For example, there would be big testing venues such as stadiums, but they would be inaccessible to certain communities, often the most vulnerable, which risked worsening pre-existing inequalities.
on a number of occasions that it wasn't clear what the strategy for a scaled up approach to testing was, and obviously if the testing site happens to be in a stadium that's some considerable distance from where a good proportion of a population live and they have low car ownership, they can't get there. So our experience is that local testing sites were much more accessible, particularly for low income populations where car ownership is much lower. If I can walk to it, I'm more likely to go to it.
Thank you very much. I've been asked to ask you, please, if you wouldn't mind trying to slow down a little bit, and don't worry, I suffer from the same issue. But I think we're just trying to catch everything you're saying, Mr. Fell. So I'd be very grateful. Thank you. And just touching on another example that you give. At paragraph 175, you talk about, again, this top-down approach. There was an expectation that local agencies would make national decisions functional, but without any consultation on those processes being developed. What was the sort of consequences of that, and what would the practical, what difference would it have made had there have been consultation on those types of decisions?
It may not have made lots of difference to the actual implementation. It's not for local authorities or directors of public health to set national policy. Never was, never will be. But it was an issue quite frequently that a change in the rules or the change in a process was made on a evening press release or one of those evening press conferences that happened most days during the pandemic. That was when we first learned of that. Local stakeholders would legitimately come to me to say, well, what does this mean, Greg? And I would be expected to have an answer. And if I'd heard at the same time as everybody else, sometimes I didn't have the answer. So then we all spend some time working out the implications. That wasn't optimal.
Thank you. And just looking at one last example, at paragraph 145, again, we don't need to go to it, but you talk about there being a concerning lack of public health expertise and advice at all levels, with a reliance on short-term secondments and consultants, and that this severely limited the opportunity to build and maintain constructive relationships. And you talk about stakeholder engagement being rushed and fragmented. What do you mean by stakeholder engagement? Who specifically are you talking about there?
An example is the one I've just given. It is the learning of a significant change to the rules or significant change to the process on the daily press call. I learn at the same time as everybody else, but I have to be on point to explain that to councillors or the leader of the council or significant other stakeholders within Sheffield. On the significant lack of public health expertise, it was a public health emergency. The Public Health England, as was a lot smaller than it once was, and local authorities were a lot smaller in terms of their public health trained capacity and capability than they once were. So we went into the pandemic with a smaller than optimal trained public health workforce to be responsible for managing what was a public health emergency.
Thank you. I just want to touch briefly, please, on the reason for the limited engagement that you describe with directors of public health to begin with, and you touch on this at paragraph 91 of your statement. If we could turn to that, please. It's at over page 21 and 22. And what you say is this: the local public health system has been undervalued by successive governments, demonstrated particularly by a lack of real-term increases in England to the public health grant. The central government response to the pandemic, and particularly the limited engagement with directors of public health in the early stages, reflects the historic lack of understanding of the importance of public health and the role of directors of public health in creating healthy populations and places. As directors of public health are responsible for their local population's health, they have information about rates of existing illness and disease, as well as a network of partnerships with individuals and organisations within communities that are ideally placed to support planning and ensure that advice is delivered to the right way to the right people. Can you tell us a bit more about what you consider to be the historic lack of understanding of the importance of public health and the role of directors of public health, please?
There's a few thoughts I'd still stand by that. I think every DPH in the country would still stand by that. A few thoughts. it's hard to maintain an infrastructure when you can't see and count what the benefits of what you do. No one can count the measles outbreak that doesn't happen. No one can count the meningitis outbreak that's closed down really quickly. That's the art of prevention. So it's hard to demonstrate that you've got value in that context, because success is nothing happens, which is quite hard when government understandably has significant resource constraints. Also, I guess, public health workforce is soft C competing with the NHS that treats people, historically a significant proportion of resources has gone to treating people, not preventing illness in the first place, and that is a thing that's in the mix. The third thing that's worth saying in that context is that the consequences of the previous government's austerity policy is that the public spend at local level is very, very much smaller than it once was. I think I've commented elsewhere in the brief that the spend in public health teams, both the team, my direct team and the services I'm responsible for commissioning, is 26% less than it was. We have less staff, and there were consequences of that. One thing that's not in there that isn't a really important context in terms of the lack of engagement was, let's take us back to the context of the time. An awful lot of developments were happening very, very quickly, and I have no doubt that was very difficult for the government to coordinate and engage as well. That is in the mix there.
Thank you. I just want to touch briefly on the historic lack of understanding point a little bit more. The inquiry this morning heard evidence from Baroness Dido Harding, and she was asked about the underutilisation of directors of public health, and she used the term a Whitehall disease for central government not to understand local government, and there being a local disease for local government not understanding central government. But in her view, we needed both central government and local government essentially to work together. And I wondered if you had any observations on that particular view.
I would concur entirely with Baroness Harding. I will talk unrelentingly about local level response. That's my job. That's what I'm responsible for, as are my colleagues. The optimal is the right balance of local and national. Local can get to places with more grip, faster and with credibility that national simply can't, but equally there is a role for national. Finding the right balance is difficult. I would also agree with Baroness Harding that there's a long-standing culture of national not understanding local, witnessed by the directors of public health of one-person teams. We're clearly not one-person teams, so but that does cut both ways, and some of that improved during the course of the pandemic, specifically in this context actually as well. That's an important lesson for the future.
Thank you. You touched on resources in one of your most recent answers, and I just wanted to ask you if you could help us with this. So given the issues with resourcing, and you touched on it in your statement, in your view, were the directors of public health still best placed to be engaged in the response in the ways that you've outlined, and did they have the capacity to do so in real terms?
No, not at the start of the pandemic. It's worth saying that it's an untested question. We'll never know the answer, but many of us would contend that we could have scaled up really very quickly, because remember, it's not just my team or my colleagues' team. The resources of the whole of the local authority were largely available to us, so we quickly repurposed call handling capacity that we use for handling a range of other things that come into a local authority to be in effect the contact tracing team. So we could probably have scaled it up very, very, very quickly, but we'll never know whether we could, because obviously that chance has gone.
Thank you. And just on this same theme, please, I'd like to take you to the witness statement of Professor Deenan Pillay, who the inquiry is going to hear from later in the week. It's inquiry reference ending 5152, paragraph 31, please. It's quite a lengthy bit of text. I'm not going to read it all out, but in essence, it talks about it being true that local authority capacity for public health has been reduced, but nevertheless, it seemed obvious that local public health structures were ideally placed to receive further investment to grow contact tracing and isolation support for the population they serviced, since this would not only build on existing expertise, but also be best placed to understand local drivers of the pandemic and how best to mitigate these risks. So just pausing there, do you agree with that analysis?
Agree entirely. It's worth saying that the shift of local level capacity for public health to the Health Protection Agency in 2007 and then to PHE in 2012, in effect, that was the local level capacity, some of the boots on ground capacity. PHE fulfilled that for us in peacetime perfectly well. That was the deal that was struck, and we, as I've said, we have local level capacity and capability for contact tracing in environmental health and sexual health services all the time. That's what they do. We have those key capabilities. We could have scaled up the capacity by use of furloughed and other staff within local authorities, but we weren't given the chance early enough.
Thank you. And just continuing with this paragraph, please. Professor Pillay says, by contrast, Serco were contracted to undertake the COVID contact tracing function with underskilled staff tasked with dealing with the heterogeneous risk within diverse populations over the telephone. He talks about there not being this not being joined up with the identification of particular risk individuals or communities. The advice on isolation was generic and one-dimensional. There seems to be a little understanding of the specific pressures people were experiencing. For example, supporting people in isolation from multi-generational households, high-risk individuals, those without private outdoor spaces, those on zero-hour contracts. And in his view, these challenges remained unevaluated without solutions being sought. And his view is that delegating such tasks to local health protection teams would ensure a more sensitive and responsive and indeed effective outcome. Do you agree with that analysis?
I can't comment on the Serco aspects because I wasn't there. I wasn't involved with that operationally. It would be fair to say that we developed local contact tracing services within each of the local authorities. Certainly, that was with call centre staff who weren't trained. We were responsible for making sure they were trained and appropriately supervised, and I'm assuming that some of that happened with Serco. I can't comment on the quality of that because I wasn't there. It's mine and my colleagues' recollection that there was perhaps an overemphasis on the process of identifying the individual with the positive test, phoning her or him up and chasing down their contacts, but not understanding the context and the life circumstances that people were in, which clearly mattered to his or her ability to isolate. And again, local trust in local stakeholders mattered. We had lots and lots of anecdotal experience that local accents really mattered in terms of developing that trust.
Thank you very much. I'm going to move on to a new topic now, and it's the topic of data. And again, the inquiry's heard quite a lot of evidence about data and challenges around data flows from the sort of central level to the local level. You touch on this in your statement, and essentially what you say, for example, at paragraph 152, we don't need to go to it, is that national bodies were slow to provide local authorities with data. This caused significant problems. For example, directors of public health struggled to get information on positive cases in their area, which meant that sometimes you were learning about cases via the media and left on the back foot. Is there anything further you want to say about that?
It was unusual that we'd have learned about cases from the media, except in the very, 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 very early days where there were a handful of cases. But it is fair to say that it did take too long for directors of public health and their teams, let's be clear, to have executable, identifiable data that we could then direct a local operational response. And that's a critical piece of learning for the next pandemic. It was 4-5 months into the pandemic, the worst public health emergency ever, the worst national emergency since World War II, that I had executable, identifiable data that I could direct an operational response. We can do better. It's a key piece of learning for me.
Thank you. We'll come back to the timeline on when the data improved in just a moment, but I just want to touch on something you say in paragraph 153, which is in general, data sharing from PHE to local authorities worked better when existing systems and processes were used, as opposed to new arrangements, which would often create data flow issues. Just on that, and this idea of using existing systems versus new systems, the inquiry heard evidence from Mr. Cook on behalf of Deloitte, And in his evidence, he talked about the development of a new system called OMIP, OMIP, which was designed to be a single source of truth, he said, of data with testing activity, results by locations and regions. And he said that the DHSE was provided that, and some local authorities had access to that platform. Were you aware of that platform?
Not unless it was also referred to by another name, but I don't recall OMIP. It sounds quite useful.
Thank you. Turning then, please, to another document. It's inquiry reference ending 4738. If we could go to page 1 of that document, and just to contextualise what this document is, you've had it by way of your witness preparation. It's an advice memo. It's an MHCLG document. We explored it with Mr. Garton from the MHCLG when he gave his evidence. And as we know, the MHCLG is a conduit between central government and local government. In summary, what this document is summarising essentially is that there are data requests from the local level and that there are some ongoing issues. Can I take you, please, to page 5 specifically of this document? What you should see in front of you, it's just a page before that one, sorry.
I think I remember that table, however.
Yeah, that one's the care home one,
Yeah.
the one just before. Yes, test and trace. Thank you very much. So I think you've seen this, Mr. Fowle. So just so we can see what we're looking at, on the left-hand side, the first column is who is asking, and we can see the directors of public health are listed in every row. The next column is what do they need, and we can see the different types of data categories that are being requested here. For example, tests and positive cases, testing performance, demographic breakdown, contact tracing information, and so on. The third column is why do they need it, and we'll come back to that. And then the last column deals with does it exist, and we can see that in 3 of those rows it does exist, subject to some caveats, and in 2 of those rows it didn't currently exist at the time of this document. So I just wanted to look at, please, in further detail, the why do they need it column. So by way of example, if we could look at the row dealing with demographic breakdown, please. It's the one just from the bottom, you can see it in front of you. And then the column to the right of that talks about that was needed to understand coverage of different communities and sectors of society to target policy change and engagement activities. And we can see in the last column that it wasn't currently available, although there were figures provided for mortality and cases. So in your view, what were the implications of this type of data not being available at this stage when it came to sort of trying to develop interventions for particular communities?
2 immediately spring to mind. One is inability to direct mobile testing sites and efforts to get people to mobile testing sites in a specific community particularly affected. And there were times when there were very, very small numbers of people affected. There were times when obviously that was much bigger. And the second is the ability to direct very local comms, either comms via me and my team, or often more importantly, working with and through voluntary and community sector stakeholders or faith leaders who, again, can get to communities with much more reach and grip and trust than I possibly could. The ability to have really granular data enables us, or not having it doesn't enable us to direct some of our interventions very precisely in a targeted way.
Thank you very much. And just looking at a few more of these in this particular column in detail, why do they need it? So, for example, details of tests and positive cases in row 1. Why do they need it? To understand who is being tested in the specific hotspots. The next category, it's channel turnout rates are needed to understand how well utilised testing centres are in different locations to better direct resources. We've looked at the demographic breakdown one, but so on and so forth. But the point is, it's right to say that and can you confirm it for me, please, that these categories of data that you didn't have at this point were crucial to your work on the ground. Is that fair?
Not having them, we carried on doing the work that we did, but with less granularity, less specificity, and less ability to precisely target. But there were undoubtedly many more iterations of the why we need specific data lines that aren't captured here. I'm sure I could remember them if needs be. But we asked and asked and asked many times. I must say credit to Public Health England teams who eventually built the data platform to enable us to have the access. It did change the nature of our response quite markedly.
And just touching on that then, in your view, when did that become available to you?
I think it was May, June, July 2020-ish. I'm afraid I can't remember the exact date, but it was 4 or 5 months into the pandemic.
Okay. I want to take you, please, to the statement of Joanna Killian from the Local Government Association. And again, you've had this statement in your pack and you've already told us that you had a close working relationship with the LGA. I'm just going to take you, please, to paragraph 52 of her statement. I'm not going to read it all, but essentially what she says in her statement is that the lack of individual level data on COVID-19 cases being shared with directors of public health at the outset made it impossible to support those affected and to control outbreaks, and goes on to say that the LGA repeatedly requested the data. Does that sort of accord with your experience?
Yes,
touched on it.
I know LGA did, I know ADPH did, and many others did individually as well.
Thank you. And if we could look at briefly paragraph 59 of the same statement. In this paragraph, Ms Killian talks about local authorities being excluded from the design of a data collection form which captured the information needed to act on a test result. And as a result, the forms are poorly designed for operational use. Can you help us, please, with what exactly these data collection forms were and how they were intended to be used locally?
I'm not sure I can, actually. I can't remember the specifics of what was on the data collection forms. I have vague recollection of being unhappy about being excluded from that, and certainly those who are very operationally involved were of the view that many fields should have been collected that weren't collected, but I can't actually remember, I'm sorry, the specifics of what were collected on the form.
That's fine, thank you very much. And paragraph 62, and again, just briefly, she talks about there being a general reluctance by government to routinely share individual test and trace data with local councils. And as a result, in her view, she says valuable time and effort was expended by local directors of public health in trying to access data that would enable them to respond better. Do you agree that there was a general reluctance to routinely share data?
Yes, for a number of reasons, one of which was a fear of breach of confidentiality, which is a true fear and should treat seriously. During the course of the pandemic, when we eventually had access to identifiable data about who was being tested, what test results were, i.e. we could map epidemiological trends, we doubtless, each authority doubtless handled many millions of lines of data. I don't think there was a single data breach in the course of the whole pandemic. We can be trusted with this data and we know what we're doing with it.
Thank you very much. And I just want to touch briefly on the sort of timeline of when the data improved. Now, Mr. Garton from the MHCLG, who I've mentioned in his evidence, suggested that the issues were essentially resolved by the end of July. But reflecting on Miss Killian's statement, and we don't need to go to it, but she deals with it between paragraphs 65 and 69, seems to suggest that issues persisted well beyond July. And I just wanted to put a series of propositions that she talks about and ask you whether you agree. The first one is that she says, despite the LGA requesting data on the 29th of July, it was not made available until some months later. And I think you've said 4 or 5 months onwards. So does that sound...
That's my recollection, yes. I can't remember the date of the big reveal where we actually got the executable and identifiable data, but from memory it was 4 to 5 months at least.
Thank you. She talks about poor quality data even when it was eventually shared. She says even by December 2020, data was poor quality, missing or incomplete. For example, lack of URPNs. Does that accord with your experience?
Yes, and it did improve over time, as is the case with new data sets, new data collections. Often it is poor quality. In this case, it was about COVID testing, but it did improve over time.
Thank you. She also reflects on issues with access and sharing, saying that when it did begin to flow, and she says it was about 10 weeks later after the request, and you've touched on this, access was hampered by multiple data sharing agreements and access protocols.
I can remember them only too well. Again, a hindsight and learning point, there should be a single data sharing agreement and a single data sharing protocol that should be generic across the whole of the country. But there were multiple.
Thank you. She talks about another issue, that councils were required to nominate a single named person.
Yes.
And they were given access, which would delay things.
From memory, I think for Sheffield, I was the single named person. My team needed the data because there's no point it just resting with me. Again, it goes back to the proposition that the Director of Public Health was a sole actor. I was acting on behalf of an institution. The right people within the institution needed access to the data, so a single named person wasn't a good solution.
Thank you. And another issue she talks about is the fact that data was fragmented across multiple platforms with different rules, logins and access rights, and it meant that data was on different dashboards, and dashboards didn't allow for the downloading of data, which posed problems. Does that accord with your experience?
That was an issue mid to late summer 2020. It did improve over time. And again, credit to those people who made it improve, because it didn't happen by magic. It happened because people eventually listened to our feedback from the front line, so to speak.
Thank you very much. I'd like to move on to a different topic now, please, and this is dealing with essentially when the local level became more involved, and in particular in relation to local contact tracing partnerships, I believe they're referred to. If we could look at paragraph 97 of your statement, please. It's at page 23. Thank you. In this paragraph, you talk about the data demonstrated that local test and trace systems helped increase the uptake. You give examples of Sandwell and Blackburn as being positive examples. Could you elaborate on those examples and particularly why this was a more effective model?
As I said earlier, this isn't about either national or local. This is about a blend of both. And early in the pandemic, we had a single national approach, which wasn't optimal in terms of the speed by which cases were completed, i.e. the case was identified and called and the contacts were found, and the case and contacts were the appropriate interventions were in place. Sandwell and Blackburn were typical examples of lots of places that had local contact tracing teams that were largely run by directors of public health or their teams, more to the point, using local authority employees quite often with close connection, collaboration with voluntary and community sector organisations that can really get into specific communities. Two things, the intelligence I received, and lots of people of directors of public health also received, that two things really mattered: local numbers, because people have more trust in local numbers, and secondly, local voices. I've still never quite got underneath why the local voices thing mattered, but that was a consistent piece of feedback throughout the whole course of the pandemic. My experience, I think the data would back me up on this, is that when we had properly and fully established local contact tracing services, we could complete cases, i.e. find the case, find the contacts and do the appropriate interventions much more quickly and with much more depth than a single national approach.
Thank you very much indeed. And just on that theme, can we turn to another document, please? It's inquiry reference ending 5177. And if we could go to page 2 of that, please. It's an article by Adam Briggs in the BMJ talking about the role of local contact tracing. And if we could highlight, please, sort of that section there. Thank you very much indeed. I'm not going to read it all, but it touches on some of what you've talked about. So, for example, some of the cases missed by the national team don't want to be reached and may never engage. Some will have incorrect contact information. Some won't have noticed the number coming through, and others will be vulnerable, socially isolated, digitally digitally deprived, transient or economically worse off. It's here where local systems can really make a difference. And then goes on to say that local teams were more successful at reaching those cases compared to the national team because they can draw on local databases to update missing contact details, having a local phone number appeared to help, as does having local call handlers. Local population can speak the right languages, etc. The capacity to visit people at home, and a heavy emphasis on being able to provide support around isolation. In summary, do you sort of agree with that analysis as to why the local model was more effective?
Yes, entirely. I agree with Adam's article. I'll draw your attention to some of my earlier comments. Language mattered. Obviously, local dialects clearly mattered, as I've said. Non-English language speakers. We had non-English language speakers in many of our contact tracing teams and drew on those. And as you say, the ability to draw on all the local databases. The council tax system, it was an incredibly effective tool to fill missing fields that weren't available and thus enable us to reach a case or one of their contacts. The other thing it's important to say is that the ability to quickly administer the isolation payment, but also the wraparound welfare support, that can only be really administered locally.
Thank you. And that brings me on to the next topic of self-isolation, which you've just touched on. Can you just tell us briefly what role did sort of your team, Directors of Public Health, have specifically in relation to supporting self-isolation?
So we administered the system whereby for those cases those people that were asked to self-isolate for whatever day it was, it started 14, it became 10, I think it became shorter later on in the pandemic, that we administered the isolation payment and got it into bank accounts as quickly as humanly possible, and did a broader wraparound support, food, medicine, other essential supplies.
Thank you. And do you, on behalf of sort of the ADPH, have any views about the adequacy of self-isolation payments?
It wasn't enough. And that was broadly accepted by many people, by many stakeholders, and many including ADPH, drew that to the attention of government on a number of occasions. It was particularly problematic if I am on a 0 hours contract or am self-employed, because there isn't any sick pay at all. And from memory, it was £500 for the period. May not have covered rent, food, feeding the kids, important things of that ilk. So I don't think it was enough, and many DSPH felt the same.
Thank you. And do you have any views about whether the adequacy of what you've just described and barriers to isolation more generally have contributed to disproportionate outcomes for those from vulnerable, marginalised groups?
Undoubtedly, transmission patterns followed occupational profiles. I could work from home, but folk work in a warehouse, folk that drive taxis, folk that work in transport can't work from home. Therefore, there's more occupational exposure. I've got a spare bedroom. I can self-isolate in my spare bedroom, but if I'm in a very, very crowded house, I can't. And that all of that will have contributed to propagating chains of transmission. If you add then onto that poorer baseline health, those in poorer health were much more likely to be severely affected by COVID infection. That will have made a difference to the eventual outcomes. COVID wasn't an equal opportunities disease.
Thank you. Touching briefly on something you describe at paragraph 85 of your statement, we don't need to go to it, but you talk about a public health principle of proportionate universalism, which requires that action be universal, but with a scale and intensity that is proportionate to the level of disadvantage. And you note that universal action, if not tailored, can widen health inequality. Would you mind just elaborating on that in the context of the TTI programme, please?
So if I'm running a universal service, it's the same service for the whole of a given population. I'll pick my population in Sheffield because it's easy. There's a fair likelihood, and experience backs this up in policy area after policy area, that I would find it easier to reach those in the more affluent parts of my city, Sheffield, and that population would find it easier to self-isolate because of larger houses with spare bedrooms and less occupational exposure because of the nature of occupations people can work from home. Therefore, by having a single universal service, I can almost exacerbate inequalities by rote of who does and who doesn't, or more likely to take up a single universal service. Hence the proportionate nature. I need to offer a different model and a different service for those with greatest need and more vulnerability. Does that help articulate?
It does. Thank you very much indeed. And turning then, please, to lessons learned and recommendations for the future. If we can very briefly display, please, paragraph 108 of your statement, page 26. Again, here you display statement of principles for contact tracing, and you list some bullet points as to what you consider would create a framework for an effective system looking forward. So you've listed whole system approach, subsidiarity, localism, minimum viable products, avoiding duplication, integration, responsiveness, data sharing, capacity and resources, proper recognition of multiple local roles and ownership. Is there anything you want to expand upon in terms of this framework for lessons to be learned?
I don't think so. I'd broadly stand by it. Sometimes there may be devil in detail, but as a high-level statement of a set of principles, I think I'd still stand by that.
Thank you very much indeed. And can we briefly please go to paragraph 139 of your statement? Here you summarise the ADPH data explainer, key recommendations for more effective data sharing. And again, you've touched on this, but essentially sharing local data with directors of public health should be default setting, consistent access, providing quality, timely access, and ensuring that data is usable, so the format of data, which we've talked about. Was there anything further you wanted to expand upon in terms of that as a lesson to be learned, please?
Not much. I'd still stand by that. There are two other things that are probably worth saying at this point. Three other things. One, this is something that can be sorted in peacetime. There will be another pandemic. We need to sort this in peacetime because we can't go into another pandemic where it takes 4 or 5 months to get executable data. My second point is building on that. There's something about the technical capability in building the right data systems to enable that. Now, that can be done now, and I hope is being done. I don't know whether it's being done. And the third point is about risk appetite. My experience is that data sharing or lack of it isn't really about the technical ability to share data. It's about risk appetite. There is a risk of a breach of confidentiality, which is a bona fide risk and needs to be managed carefully and appropriately. But equally, there's a bona fide risk of not sharing data, as we learn to our cost.
Thank you very much indeed. And if I could turn, please, to another document ending 4857, starting at page 1. You've seen this as part of your evidence prep for today. It's a report from Independent Sage titled A Blueprint to Achieve an Excellent Find, Test, Trace, Isolate and Support System. And the inquiry has looked at this with other witnesses. If we could turn, please, to page 2 very briefly, bullet point 1 and a summary of the blueprint. Independent Sage talks about calling for the replacement of the failed, falsely named and private sector-run NHS test and trace with a system for England which is rooted in the regions of England and in local areas. It must be integrated throughout with the NHS and provide for the needs of people and the communities in which they live. Do you agree with that sort of proposition?
Broadly, I wouldn't comment on the failed and falsely named private sector. That's a political call. That's not for me to make. But we can have the basics of a scalable testing and tracing system for a future pandemic. A future pandemic may have more or less of a requirement for testing and tracing depending on the nature of the illness, the virus or the bacteria and its characteristics, but it's fairly likely that we will need some form of capability and capacity, which we already have at local level and to a large extent already exists within the the UK Health Security Agency regional teams as well. They are very competent in such matters and do that for outbreaks that have happened since the COVID pandemic as well.
Can I ask, sorry to interrupt, do you agree it should be integrated throughout with the National Health Service?
The anchorage to places matters. I'm not a part of the National Health Service. I'm an employee of local government. I'm not wedded to the fact it should be part of the National Health Service or not. It should be anchored to places, and if I'm responsible for it, preferably with some links to me and my team and the capabilities that exist within local government. Because again, it isn't a me and my team thing. This is a corporate responsibility or a corporate capability.
Thank you. And can we turn to bullet point 3, please, on the same page? It talks about in each top-tier local authority, the local director of public health should have the leadership role and convene the necessary management structure in conjunction with the local NHS and local authority. Do you agree that it should be the director of public health that has that sort of leadership role?
If it's a public health emergency, then yes, it probably ought to be somebody qualified and capable in public health.
Thank you. And if we could just turn over the page very briefly, please, looking at the new organisational principles. Number 1 talks about operating at as local a level as possible, building community solidarity, which would encourage individuals to come forward for testing, utilisation of local civil society organisations, especially those from deprived and minority ethnic populations. Do you agree with that sort of proposition?
100% agree. The role of voluntary and community sector organisations, faith organisations, was wholly unsung during the course of the pandemic and after the pandemic. It was absolutely critical to get to places with credibility that bluntly I couldn't have got to.
Thank you very much. We can take that down now. In your witness statement, we don't need to go to it, but it's at paragraph 202. You talk about TTI systems should be designed and delivered by teams that have a thorough understanding of vulnerabilities and inequalities, and you've talked about that in quite a lot of detail. Are there any changes that you would recommend to ensure that those principles are implemented in future public health responses?
Probably not changes. It's just, I suppose, however we do the design, wherever we do the design, clearly there are some process issues that need to be attended to in running a test, trace and isolate system. One of the weaknesses of the system that we had was it tended to focus on the process, the completion, rather than the complexity of someone's lives. People weren't able to afford to isolate for 10 days because they have to feed their kids, and if they're on a 0 hours contract, they've still got to feed their kids. So the understanding of how test, trace and isolate plays out in the context of the complex lives people have is, I'm not sure how we develop that as a design principle, but it does matter.
Thank you. And in your view, should directors of public health be given a more formal role in national level emergency planning and testing infrastructure design to ensure that these types of issues are accounted for from the outset?
Possibly. Worth remembering that directors of public health, they're responsible for local authority or health board populations, not national. So a voice and a perspective rather than a responsibility. I'll happily accept a responsibility, but I'm responsible for the population of Sheffield. That's the day job. So there's something about making sure the voice is heard rather than becoming directors of public health and their teams becoming the National Public Health Agency. We aren't. So there's a nuance in there that needs to be thought through.
Thank you very much. And the last question from me, Mr. Fell. You deal with lessons learned and recommendations at length in your statement between 189 and 207, and we've covered those themes: communication and data sharing, poor recognition of the role of directors of public health, a disconnect between the national and the local vulnerabilities, and public health capacity, resources and funding. But was there anything else that you want to say at this juncture in terms of any lessons to be learned for the future, or any recommendations for my lady to consider?
2. One is we mustn't neglect regional teams in this. We've talked local and we've talked national at some length, but there was regional coordination here as well. So we should make sure that we consider multiple levels of geography. And the second addition is scope of planning and response. Going into the pandemic, COVID was seen as a public health issue, therefore public health professionals should respond. It was blatantly apparent very, very quickly that a whole of society response was needed and was eventually what was put into place. The next pandemic may be the same. The previous pandemic was a swine flu pandemic. It wasn't as severe. It didn't require a whole of society response. The next one may or may not, but we should plan accordingly because we learned the hard way that COVID, this pandemic was definitely a whole of society thing. So we should plan and exercise accordingly.
Mr. Fell, thank you very much indeed for your assistance. My lady, those are my questions.
Thank you very much indeed, Mr. Fell. That completes the questions that we have for you. Thank you for your contribution. They've been extremely helpful. And thank you to you and to all your colleagues around the country working or leading public health teams for all the support and the attempted protection that you gave to all your communities. So thank you very much indeed.
Thanks, my lady. I shall pass that on.
Very well. 10 o'clock tomorrow.
All rise.